Here's our roadmap for today. We're moving chronologically, starting with hemorrhage and hemostatic modalities, then hitting the principles and hazards of electrosurgery, checking out advanced vessel sealing devices, and wrapping up with surgical drain classifications, specialized drains, and their removal. Kicking things off with Section 1, hemorrhage and hemostatic modalities. This is the absolute most critical problem you'll encounter in any operating theater. So, looking at the timeline of surgical bleeding, primary hemorrhage is what happens right there on the table. But the reactionary window, that 24 to 48 hours post-op, is where things get physiologically interesting. During surgery, a patient's low blood pressure or natural vasoconstriction might temporarily hide a bleeder. But once they're in recovery and that blood pressure normalizes, boom, the temporary clot dislodges and bleeding resumes. Then you have secondary hemorrhage, which can happen days or weeks later. And that is almost exclusively driven by a deep-seated active infection that literally erodes right through a blood vessel wall. But before we actually stop the bleeding, we have to establish the absolute golden rule of surgery. Never, ever place clamps or sutures blindly into pools of blood. It is a recipe for disaster. Groping around blindly with a clamp can easily cause permanent vascular thrombosis or sever a collateral nerve, leading to catastrophic collateral damage. You must have direct visualization first, no exceptions. Once you've actually got eyes on the bleeder, surgeons are going to reach for one of these 4 modalities. You got your direct mechanical methods, like pressure and ligatures, and thermal methods, like electrosurgery. But look at the chemical and topical agents down there. These are brilliant. The physical topical agents, like oxidized cellulose, act as a physical scaffold for fibrin and can absorb up to 40 times their weight in blood. It's a massive direct tamponade effect. On the flip side, the biological agents, like direct thrombin, are sprayed on to actively and biochemically kickstart the patient's own physiological clotting cascade. All right, moving to Section 2, Principles of Surgical Electrosurgery. Let's look at the physics behind the most ubiquitous thermal tool in a surgeon's arsenal. So here's a wild number for you. Electrosurgery relies entirely on alternating current, right? But your standard wall outlet supplies current at 50 to 60 hertz. If you applied that to a human, you'd catastrophically stimulate their nerves and cause massive muscle spasms. So how do we avoid that? Notice this massive jump in frequency. Electrosurgical units convert electrical energy into incredibly high radio frequencies, anywhere from 500,000 to 3 million hertz. That is way above the 10,000 hertz nerve stimulation threshold. By operating at these massive frequencies, the current safely bypasses the nervous system altogether and converts pure electrical energy directly into thermal heat right inside the target tissue. This is a fantastic illustration of how that current actually travels. On the left, we've got monopolar diathermy. Here, the current travels from a single active electrode right through the patient's entire body and exits safely via a massive dispersive return pad on their skin, routing back to the generator. On the right, we have bipolar diathermy. In this mode, the current only flows through the tiny piece of tissue captured between the 2 prongs of the instrument. Because bipolar strictly confines the current between those prongs, meaning you don't even need a return pad, it is the absolute mandatory choice for operations near sensitive neural areas, like the recurrent laryngeal nerve, or for patients with implantable pacemakers. Let's look at the waveforms, because comparing these modes side by side makes the mechanism crystal clear. Look at the cutting mode. It uses a lower voltage, but a continuous waveform. The current is literally on 100% of the time. This concentrated energy instantly vaporizes cellular fluid, giving you a perfectly clean cut with minimal lateral thermal spread. Now contrast that with the coagulation mode. This one uses a higher voltage, but an interrupted waveform. The current is actually only flowing 6% of the time and rests for 94%. The slower dispersed heating causes cellular dehydration and protein denaturation. It literally twists the vessel walls and stimulates the clotting cascade, but it definitely results in extensive lateral thermal spread. Section 3. Hazards of Surgical Diathermy. Playing with high-frequency alternating current is incredibly effective, but it comes with severe intraoperative hazards. While burns are definitely the most frequent complication, especially in monopolar mode if that return plate loses contact, surgeons also have to manage a whole host of invisible hazards. A single spark can instantly ignite invisible, volatile vapor pools from alcohol-based skin preps. You've also got channeling, where current applied to a narrow tissue stalk hits a bottleneck, concentrating the energy and unintentionally charring distant structures. And we can't forget surgical smoke. That smoke you see during a procedure isn't just an annoyance. It's packed with live viral particles, bacteria, and severe respiratory carcinogens, which is exactly why active smoke evacuation systems are mandatory.
Now take all those dangers and put them into a laparoscopic or keyhole setting. The risks compound heavily because your field of view is completely limited to the camera. Lethal electrical coupling can happen if an instrument's insulation cracks along the shaft, or if the active tip accidentally touches another metal instrument. A surgeon might inadvertently step on the foot pedal when the tip is just millimeters outside the camera's immediate frame. Even residual heat is a massive hazard. A deactivated tip can still hold enough thermal energy to severely burn a vulnerable piece of bowel if it just grazes it on the way out. Moving into Section 4, Advanced Vessel Sealing Devices. To mitigate those hazards and vastly speed up operative time, bioengineers stepped up to the plate. These devices can safely divide massive 7mm tissue bundles, and this comparison highlights two completely different cutting-edge mechanisms. On one side, we have advanced bipolar technologies like the LigaSure. This uses calculated physical pressure and electrical impedance feedback to literally melt and fuse the structural collagen and elastin right in the vessel wall, creating a seal that can withstand 3 times normal systolic blood pressure. On the other side is ultrasonic energy, like the harmonic scalpel. This uses zero electrical heat. Instead, a handheld transducer mechanically vibrates a blade at up to 50,000 hertz. It physically whisks the proteins apart, kind of like whisking an egg white, achieving complete denaturation and hemostasis through pure vibration. And then you have combination energy devices like the Thunderbeat, which take us right to the bleeding edge. These brilliantly merge both ultrasonic mechanical vibration and advanced bipolar technology simultaneously within a single jaw. It gives the surgeon the ability to achieve maximum rapid hemostasis and division of large vessels, while completely eliminating the production of obscuring mist or carcinogenic smoke. It's the best of both worlds. Section 5. Surgical Drain Classifications. We've covered cutting and coagulation. Now let's switch gears to the post-op phase and the highly debated topic of drainage. For well over a century, surgeons just blindly followed this famous 1887 edict from Lawson Tate. When in doubt, drain. The logic was simple. Always leave a channel for noxious fluids, blood, or pus to escape. However, modern evidence has totally flipped this on its head, turning routine drain use into a highly controversial, strictly regulated clinical decision. We know now that placing an unnecessary drain can actually artificially introduce skin bacteria directly into the sterile peritoneal cavity, jacking up infection rates and prolonging hospital stays. But when a drain is definitively indicated, you're looking at 3 main types. First, open drains like corrugated rubber. These rely purely on passive gravity and capillary action, but they act as an open two-way street, severely increasing the risk of bacterial colonization. Second, closed suction active drains. These maintain a constant negative vacuum to actively suck out fluid and obliterate dead space, which is highly useful after a major hernia repair to stop a hematoma. Finally, closed, non-suction passive drains. These use gravity to evacuate fluids but have zero vacuum. That makes them absolutely perfect for inside the abdominal cavity, draining fluid without dangerously sucking in or trapping the delicate bowel tissue or adjacent omentum. Because of all those risks, modern placement guidelines are strictly categorized by specialty. Drains are aggressively avoided in routine GI cases, like colonic resections or a standard gallbladder removal to prevent delayed recovery. But take a look at the emergency GI category. Dogmatic avoidance goes right out the window here. If a patient presents with massive, heavy 4-quadrant peritoneal contamination, routine drainage isn't just considered, it's an absolute necessity to get that purulent, toxic fluid out of there. Finally, Section 6, Specialized Drains and Removal. Let's look at the exact evidence-based protocols for managing and safely removing these devices. Take the nasogastric, or NG tube, for example. Modern enhanced recovery after surgery, or ERAS pathways, absolutely forbid the prophylactic, prolonged use of NG tubes in elective settings. However, they are still strictly indicated to decompress the stomach during a postoperative paralytic ileus or bowel obstruction. But you really have to watch the contraindications. You must never place an NG tube blindly if you suspect a base of skull fracture. If you do, you've risked the horrifying complication of accidental cranial intubation. Prolonged use also risks pressure necrosis on the nose and severe reflux esophagitis. Next up is the highly specific removal of a T-tube. These go into the common bile duct after stone retrieval to act as a pressure safety valve while the sphincter of Oddi is in post-op spasm. You can't just yank this drain out. It has to stay in for at least 2 to 3 weeks to guarantee a solid, mature fistulous tract has formed around it. Once it's mature, you follow a rigorous 4-step checklist. First, a cholangiogram proves there are no retained stones and contrast flows freely into the duodenum. Then, you clamp the tube for 24 hours. If the patient has zero pain, proving there's no distal obstruction, only then do you safely pull the tube, knowing that mature tract will heal completely on its own.
For other drains, the big overarching rule across all these removal protocols is this. You extract the drain the exact moment its specific clinical objective is met. Never just wait around for an arbitrary fluid volume to drop. Bleeding signal drains come out at 24 hours. And here's a crucial mechanical rule. Always, always turn off the active vacuum suction before physically pulling a drain so you don't tear internal tissue. For chest drains, it requires precise physiological maneuvers. The patient performs a Valsalva maneuver, taking a deep breath and forcefully holding it, maintaining positive intrathoracic pressure so atmospheric air doesn't suck back into the pleural space while the tube is pulled.
Which brings us to a final, pretty provocative thought to leave you with. Does a drain actually stop a surgical leak from happening, or does it merely convert what would be a life-threatening internal peritonitis into a visible, externally controlled fistula? It's a question that beautifully summarizes the delicate balance between necessary intervention and iatrogenic harm in modern surgical practice. Thank you so much for joining me on this explainer as we broke down the physics of hemostasis and the strict logic of drainage management. Keep learning, and I'll see you in the next one.